Okay, welcome to the Nursing Health History unit. This unit actually consists of two parts. The first being therapeutic communication techniques, and the second part is how those techniques are used to gather a patient health history. So know that communication is what we use to establish a relationship. Every message of that communication has a purpose or an objective. The sender intends, whether consciously or unconsciously, to accomplish something by communicating. So therapeutic communication is really defined as that face-to-face process of interacting that focuses on advancing the physical and emotional well-being of a patient. So note that it is very patient-centered. In other words, what we're doing is assisting the patient to work through their feelings and explore options related to their unique situation. So this kind of communication really has three general purposes. The first one is collect information to determine what's going on from the patient perspective. The second is to assess and modify behavior. And the third is to provide health education. So having that definite purpose is in fact one of the principal differences between having a casual conversation and therapeutic communication. So by using that therapeutic communication, what we're attempting to do is learn as much as we can about the patient and their perspective of what's going on with them at that time. In doing so, we need to be consciously aware of the confidentiality of the information being disclosed and received during the communication process. We always must have a therapeutic reason for invading a patient's privacy. We're not asking these questions or delving into their background to be nosy. We need to have that therapeutic reason. And if we don't need to know some personal information about the patient, then we don't ask. So again, be focused on what is going on with the patient and then guide your communication to provide better care or to plan better care for your patient. So again, that communication is a process of passing information and understanding from one person to another. As your textbook mentions, many people mistakenly assume that if they can talk and hear, they can communicate. But communication is much broader than that. The communication process actually involves 6 basic elements: the sender, the message, the channel, the receiver, the noise, and the background or feedback. So nurses can improve their communication skills by being aware of all those elements and how they contribute or interfere with successful communication. So remember that if the meaning of the message is not conveyed, then communication really didn't take place. And communication can easily break down at any one of these elements. So nonverbal communication is communicating a message without words and can be as important and sometimes even more important than the verbal communication. When used to collect information, therapeutic communication requires a great deal of sensitivity as well as expertise in using interviewing skills to ensure that the identification and clarification of the patient's thoughts and feelings. You as the interviewer must also be observing the patient's behavior. So listen to the patient and then watch how they listen to you. Observe how the patient gives and receives both verbal and nonverbal responses. And then finally, you are going to be interpreting and recording the data that you've observed. Now, taking notes can be very distracting and concern the patient. So if you need to take notes, be sure to let the patient know that the information is being collected for the purpose of their care. Typing directly into the EMR or the electronic medical record while the patient is talking can be very distracting and take attention away from the focus on the patient. So many nurses will find a way to either discreetly write down notes and then let the patient know that this information will be put into the EMR when the conversation has concluded, or we may interview the patient for a period of time and then let the patient know, at this point, I'm going to take a break and I'm going to enter some of this information that you've been telling me into the computer. And as soon as I've got that done, then we'll pick up where we left off. So trying to interview and enter the information in an EMR is again very distracting, and many patients have expressed feeling that they are not a, important during that process. So there are some other factors that influence communication, one being the patient's developmental level, the gender, some sociocultural differences, and then even the space between us and the person that we are talking to. So intimate distance is that closest, and it involves some touching or physical contact. For example, bathing the patient, or when we're doing the actual physical assessment with our stethoscope. Personal distance may also involve some touching or physical contact. This is more at arm's reach. For example, we may pull up a chair and be sitting at the patient's bedside. And this personal distance is usually the most appropriate for the interview process. Social distance is out of reach for touch. Communication from that point seems to be a little bit more formal. And then public distance is an example of that would be standing up in front of your coworkers giving a presentation. So some things that promote communication. One thing to consider would be to introduce yourself to the patient, call the patient by their formal given name, and then ask them how they would like to be addressed. Explain the purpose of the interview so that you establish that basis of trust, so the patient understands why you're asking all these rather personal questions. And then try to control the environment to minimize any distractions and interruptions, and then think about the comfort level of the patient. Some things that you can do in the hospital setting would be to draw the curtain, shut the door, check to see if the patient is comfortable, if they need a pain medication, if they need to use the bathroom. Again, make sure that everything, all the barriers to communication are taken care of as much as possible before you get started. Also, be familiar with the institutional policy on patient confidentiality. Be ready to explain to the patient what information is going to be shared with others and under what circumstances. Listening skills are central to therapeutic communication. As a nurse, engaging in active listening will facilitate developing rapport with the patient and also facilitate that patient communication. No doubt you can think of an occasion when you had a conversation in which you did not feel that you had the patient's or the person's full attention. And how did that make you feel? In that circumstance, would you have really wanted to discuss personal information? So remember that it's always important to convey that the patient is the most important person present during your conversations at that time. There are some special considerations. Patients will present with special circumstances that require the nurse to alter the usual approach to interviewing. So one common theme for all of these, whether you're dealing with a patient that is hearing impaired, visually impaired, has a speech impairment, or is non-English speaking, is that you will need to allow additional time to complete the interview or to gather the information that you need. So when it comes to interpreters, remember that using children in the family, other relatives, or close friends as interpreters violates privacy laws because patients may not want to share personal information in such cases. Additionally, friends and family who are unfamiliar with medical terminology may misinterpret information. There are some blocks to communication. Your textbook calls these the 10 traps of interviewing, and it provides excellent examples of these. So no matter whether you're a novice to therapeutic communication or you're a seasoned nurse, we all will fall into one of these traps at one time or another, because we are really looking to alleviate the patient's discomfort and make them at ease. But these traps can cause the patient to become angry, confused, and withdraw from the conversation or interaction. So open-ended questions are often used to elicit general information. What we're looking at is how, what, why, actually not why, how, what, where, when, and who, such as, what can I do to help you today? Closed-ended questions are used to focus the interview, gather information quickly. So an example of this would be, are you allergic to any medications? Facilitation or a general lead encourages the patient to expand on the information that has already been offered. And you can either do this verbally, saying something such as go on, or through nonverbal communication such as nodding your head. Clarifying is the purpose to understand exactly what the patient is saying. And this can be used when you think that what the patient is saying and their nonverbals are not in sync. Reflective provides the opportunity for the patient to expand on what was just said. It's important that as a nurse, you not give advice, pass judgment, or assume responsibility for the patient's thoughts or feelings. Sequencing gives you that chance to verbalize a conclusion you have from the information so far. You may be able to put together the pieces that the client did not see, or you might be incorrect, and this allows you the opportunity to reassess. So an example of this, of sequencing, you can say, tell me when the pain first started, how long it lasted, and what made it go away. Silence can be discomforting to some. However, it can be used to show respect, acceptance, and allow the patient to gather their thoughts or prompt more information. So if you're not sure what to say, silence often is a good technique to fall back on. The therapeutic relationship, remember that this is a professional nurse-patient relationship, so it's very different than a social or friend relationship. You are going to have the patient sharing things with you that you are not going to reciprocate and share with them. So for example, the patient may be sharing information about their bowel habits. Well, you know, in a friend relationship, you may say, oh, sure, I've experienced that too. But now with the nurse relationship, you are simply gathering the information, and you are not sharing that type of information back with the patient. So before you meet with the patient, you will often have received background information through nursing report or quickly reviewed the chart. Gather the supplies you need, such as your health history form or even just a pen and scratch paper, and then plan for enough time to complete the interview or the interaction. During the introductory phase, be sure to introduce yourself, your title, and why you are there. Ask again how the patient would prefer to be addressed, and you can always start out with some social small talk, because at this phase, what you're looking to do is to build rapport and ease the patient's anxiety. Then you move into the working phase, and this is really the bulk of your therapeutic conversation. This is where you will be using the therapeutic techniques to interact with your patient. And then you have the closing phase, where you will wrap up your conversation. Allow time for the patient to add any additional thoughts, clarify anything that may have been misunderstood, or information that might not have been uncovered during the working phase. So let the patient know what's going to happen next, both with the information just provided and with the patient themselves. So these are some examples of some real comments by nursing staff heard during report. If you were the patient or member of the patient's family, how would you feel about the staff if you were to overhear these? And then as the nurse coming on for the next shift getting this report, what would your views be as to how the shift will go or the patients that you will be caring for? Note that when we say these type of things, we are making a judgment or passing on a judgment about our patients to the next staff. So again, before you make any judgments about the patients and the family, take a few minutes to consider what's really going on. Remember that whether your patient's in long-term care or the hospital setting, that setting is familiar to you as a healthcare provider, but it's very foreign to our patients. Patients experience a loss of control when they enter a healthcare facility. The patient is unfamiliar with the terminology that they are hearing around them and the routines of the unit. As a nurse, you will have the ability to make a significant impact on their view of the experience simply by being non-judgmental and being that bridge for them as to this new setting that they find themselves in. As you work with patients across the lifespan, these considerations on your slide are just some general guidelines to keep in mind. So moving on to the nursing process and nursing assessment with the health interview. So the nursing process is a very systematic, patient-centered method for structuring the delivery of nursing care. So what I mean by systematic is that it really follows a prescribed set of steps. The process involves critical thinking overall, which is essential to decision-making and problem-solving. Critical thinking is really the ability to recognize a problem, gather the appropriate data, analyze that data, and then draw a conclusion that's justifiable, and then make a decision as to what you're going to do for the care. So all of this requires logic and good communication skills. You will be covering the nursing process and fundamentals, and you're going to apply those concepts throughout the program and your career. So a brief look at the 5 steps. The process can be applied to an individual, to a family, or to a community. Assessment is the establishment of a database of information for a patient. This phase is important because all other steps depend on the accuracy and the reliability of the assessment information that's been gathered. Diagnosis is the statement of a patient problem that has been identified from the collection of data during the assessment. Nursing diagnosis is a clinical judgment that provides the foundation for selecting nursing interventions to achieve the outcomes for which the nurse is accountable. So planning is the phase that refers to the identification of the nursing actions or the strategies that are going to be put in place to achieve the desired outcome of nursing care. It should include both short-term and long-term patient-centered goals. So that means that the patient should also be involved in this process of planning so that they can help set the goals. Implementation is the action phase. This is where the nursing actions or interventions are actually performed. These actions not only include direct hands-on nursing care, but also teaching, motivating, communicating, and recording data. And then evaluation is the final phase of the process. This is where the nurse will examine whether the actions that we've done achieve the desired outcome or goals. And what this does is allows us as the nurse to determine, does the plan need to be altered to better meet the patient needs, or is it being effective? So again, assessment is the first step in the nursing process, and it's critical because it forms the basis on which all the other steps are formed. So as mentioned in your book reading for today, it's the orderly collection of information concerning your patient's health status. So subjective data is the data that cannot always be verified by an independent observer. Subjective data is what the patient tells you they're feeling. Objective data is the data that is directly observable, measurable, and can be verified by more than one person. And this information is gathered through the physical exam or lab findings. So again, this slide just demonstrates the difference between subjective and objective data. So remember that your actions, both verbal and nonverbal, will influence the patient's feelings and their ideas regarding your level of competence, the role of the nurse, and their perception of the healthcare setting that they find themselves in. Also keep in mind that the patient is the one who knows more about what they're feeling and experiencing than anyone else. There are different types of health history. The complete health history is very comprehensive. It's typically obtained during an annual physical exam or when establishing with a new healthcare provider or at the start of a hospital admission. The focus health history is for a limited or short-term problem. An example of this would be a patient who is seeking care for a sore throat. In this case, the nurse would focus on the length, the severity, and the timing of the sore throat and any related symptoms to that sore throat. An interval health history is also limited in scope to the problem being followed. An example of this would be a patient that's diagnosed with hypertension that comes back after having been on medication for a month. And we're going to see how that medication has been effective or not. And then there's an emergency health history, which gathers the information necessary to intervene and resolve the immediate problem. And the nurse would defer obtaining other details until the patient is stable. So in this case, we prioritize what information is needed to be gathered. So the purpose of the health history is to gather subjective data from the patient. This history forms the foundation for planning our care and then is combined with the physical exam to form the nursing database. The individual patient is considered the primary data source. Charts and family members are considered secondary data sources. So collecting biographical data is what begins the interview process. It's important to have up-to-date information so that the patient can be contacted after their visit or stay if necessary. Now, some of this information might be sensitive for patients to disclose, such as their insurance or billing information. However, asking about this information can also offer the patient the opportunity to express concerns about how they will pay for their care. And then that allows us as the nurse to make that referral to the insurance or financial department so that arrangements can be made and that burden can be taken off the patient. The reason for seeking care should be a brief statement in the patient's own words about why he or she is making the visit to the healthcare provider. The nurse can elicit this by simply asking, "Tell me why you came to the clinic today," or "What happened that brought you to the hospital?" Notice that there's absolutely no lead in at all. It's wide open and the patient then can express in their own words why they're there. So once the reason for seeking care has been established, the nurse can then look at obtaining the 8 critical characteristics. So the location is where is the problem, such as the pain, located. The quality describes the way it feels to the patient. So for example, if we're looking at pain, the patient can describe it as a stabbing, aching, or throbbing pain. The quantity is usually, if we're looking at pain, looking at a scale of 0 to 10 to describe. The timing, we look at the onset, duration, and frequency. When did the problem begin? How long does it last? How often does it happen? The setting is what the patient was doing when the symptoms began. Aggravating or alleviating factors are what makes it worse or what makes it better. Any associated symptoms or factors is the primary symptom associated with any other symptoms. For example, if the patient is having pain, are they also having numbness and tingling? And then the patient perception. How is this affecting their day-to-day activity? What do they think this means? So the mnemonics are up there for the PQRSTU. And this is also explained in your book, so it kind of helps you remember all of these 8 characteristics. Your book also goes into greater detail as to what is covered in the past medical history. When gathering this information, be sure to obtain either the date, year, or the patient age at the time that something happened. For example, you would record patient reports having chicken pox at age 5, or patient states they were diagnosed with hypertension in 1996. That just gives us an idea of, is this a long-standing problem? Is it a recent problem? And so on. Also helps us tell a little bit about how good the patient's memory is. The nurse may also ask about the health of close family members, such as parents, grandparents, and siblings. That will help identify issues that the patient may be at risk for. A genogram is actually a pictorial of that history. And then this way we can quickly see familial tendencies just by drawing out this schematic. The review of systems is the series of questions about each of the body systems, and this helps us identify any concerns or problems as a part of the comprehensive health history. The sequence and format of this review varies with the setting and urgency of the problem. Again, in an urgent situation, the nurse may omit any questions that do not pertain to that particular emergency. So be sure to record the presence or absence of all symptoms. Otherwise, it's not clear if the question was addressed or not. And sometimes what isn't present can be as important as something that is present. For example, if you're assessing a wound, the observation that the wound has no drainage, no swelling, and no redness are all very important observations. And we refer to those as pertinent negatives. So they're important negatives. Functional assessments focus on the health patterns that affect the patient's quality of life. Functional assessments are not performed on every patient. These are more in-depth assessments of a particular area. As some of these questions are quite personal in nature, it's best to address these after establishing the therapeutic relationship with the patient and earning their trust. There are tools or instruments available that focus on the specific functional categories that may help further identify if there is a problem and then any potential nursing diagnosis that may be centered on that problem. So using that standardized tool that's available will objectively measure the patient's current status and then also can be used to monitor the patient over time. A couple of the common functional assessment tools for ADLs, substance abuse, and intimate partner violence will be discussed next. So these are activities of daily living. Activities of daily living are those abilities that are necessary to perform self-care and live independently. These are some assessment tools that we can do that. These assessment tools help us assess the ability of the patient to live independently, and these can be used to monitor the patient over time to let us know if they're improving or declining in their ability. The CATS Index of Independence in Activities of Daily Living, commonly just referred to as the CATS ADL, is the most common instrument to assess functional status. And then again, nurses typically use this tool to detect problems in performing activities of daily living, and then we can plan care accordingly. The index ranks the adequacy of performance in 6 functions of bathing, dressing, toileting, transferring, continence, and feeding. Patients are scored yes or no for independence in each of those 6 functions. A score of 6 indicates full function, 4 indicates moderate impairment, and 2 or less indicates severe functional impairment. There are some limitations to the tool. It does not assess those more advanced activities of daily living, such as the ability to do housework, get out shopping, managing the finances, and using technology such as a cell phone. Although the CATS is sensitive to changes in declining health status, it's also limited in its ability to measure the small increments of change seen in the rehab of older adults. A full comprehensive geriatric assessment should be done when appropriate. Another functional assessment to consider is related to substance abuse. So the purpose of the assessment is to identify as many potential or actual abusers as early in their use or abuse history as possible so that the appropriate intervention services can be provided. The stats I have from 2013, more Wisconsin residents died from drug overdose than motor vehicles, suicide, or firearms. The Wisconsin State Crime Lab cases involving heroin have increased by 419% between 2008 and 2014. In 2014, there were 843 drug overdose deaths. 392 or 47% of those deaths were attributed to prescription opioids, and 28% were due to heroin. So the audit is the Alcohol Use Disorders Identification Test. The audit C is a 3-question version of the full audit, and healthcare providers often start with the abbreviated version to screen for alcohol use and then move to the full audit if the short version indicates a potential problem. There is the CAGE. The CAGE will fail to identify many patients with at-risk drinking who are not alcohol dependent. At-risk drinking is drinking above the recommended limits that increases a patient risk of injury and/or medical problems. The TWEAK is a 5-item questionnaire that was originally developed for pregnant women at risk for drinking problems. It's been expanded to be used in other settings because it does provide a quick and easy method of targeting outpatient and inpatients in need of a more thorough assessment of their drinking pattern and alcohol-related issues to determine whether treatment for alcoholism is warranted. And then the SMAST, or the Short Michigan Alcoholism Screening Test, is also a fast and reliable alcoholic test that can screen for or diagnose alcohol dependency. It's a 13-question screening tool. So there are screening tools also for opioids and other drugs of abuse, but those have not been in use as long and have not been researched as much as the alcohol screens. As a nurse, you should also assess patients for their risk of abuse and neglect by assessing for the risk factors associated with this and also for any signs or symptoms of neglect or abuse that the patient may have at the time of the assessment. Current research indicates that abuse and neglect affect all people of all ages. However, there are some risk factors associated with victims, and there are also some risk factors associated with the perpetrator that have a correlation to abuse and neglect. These risk factors place the perpetrator at risk to abuse others, and there are risk factors that make a victim more vulnerable to abuse. So some patient populations that are more at risk of abuse and neglect than other populations of patients include females, pregnant women, infants, children, patients that are cognitively impaired, developmentally challenged persons, those with physical or mental disabilities, and the elderly. So as I mentioned, no group is immune to intimate partner violence. It occurs in all cultures, ethnicities, races, education levels, and socioeconomic levels. A healthcare visit might be the first time that a patient feels safe to confide their fear or their experience of violence. This type of violence can occur among heterosexual or same-sex couples and does not require sexual intimacy. About 1 in 4 women and nearly 1 in 10 men have experienced contact sexual violence, physical violence, and/or stalking by an intimate partner during their lifetime, and they will report some form of IPV-related impact. Over 43 million women and 38 million men in the U.S. currently have experienced psychological aggression by an intimate partner in their lifetime. So to assess, use open-ended questions such as, how are things going at home? How do you feel about your relationship? Do you feel safe at home? So awareness and assessment are crucial to stopping the cycle of violence and assisting those that are being victimized towards safety. Children under the age of 18 may be exposed to abuse and neglect by a parent, a caregiver, or another person in a custodial role, such as a clergy person, a coach, or a teacher. While child abuse can occur in any household, children living in poverty experience more abuse and neglect. Rates of child abuse and neglect are 5 times higher for children in families with low socioeconomic status compared to children in families with higher socioeconomic status. The Centers for Disease Control and Prevention defined elder abuse as an intentional act or failure to act by the caregiver or another person in a relationship involving the expectation of trust that causes or creates a risk of harm to an older adult. An older adult is defined as someone as age 60 or older. Each year, thousands of adults over the age of 60 are abused, neglected, or financially exploited. This is elder abuse. And abuse can happen in many places, including the older person's home, a family member's house, an assisted living facility, or a nursing home. Human trafficking is a form of modern slavery. It occurs when a trafficker exploits an individual with force, fraud, or coercion to make them perform commercial sex acts or work. There are two types of trafficking. There's labor trafficking, where individuals are forced to work or provide services by force, fraud, or coercion. And then there's sex trafficking, where adults or children are engaged in commercial sex by force, fraud, or coercion. Since human trafficking is often a crime that's hidden in plain sight, it's important to be aware of the warning signs that it is occurring. Some indications that a person may be a victim of human trafficking include appearing malnourished, showing signs of physical injuries or abuse, avoiding eye contact or social interaction. They avoid authority figures or law enforcement. They seem to adhere to a scripted or rehearsed responses during the social interaction that you have with them. They may lack official identification documents. They may appear destitute or lacking personal possessions. They may be checking into hotels or motels with older males, referring to those males as a boyfriend or daddy, which is often street slang for a pimp. They may have poor physical or dental health. You may see tattoos or branding on the neck or lower back, and they may have untreated sexually transmitted diseases. In concluding the history, don't end the interview abruptly. Take the time to summarize the data that you've gathered. This allows the patient to have the opportunity to clarify any information that you may have misinterpreted, and then offer any additional information that may be important. Finally, we can't talk about gathering nursing data without addressing how that data is recorded and communicated. The patient record serves as a legal document that records the patient health status and any care that he or she receives. Prompt reporting and recording of the patient assessment data is essential to providing and ensuring safe and efficient care. So again, the purposes of the medical record, again, are listed on your slide. It's not just a legal document, but it's what we use for care planning, for quality assurance, for financial reasons, education, and research. The patient's record is not organized like a book in which you can read the patient's story from beginning to end. The patient's record is instead organized into sections, and as a nurse, you will become very skilled at finding the pertinent information that you need very quickly. There are some principles of documentation, and quality documentation follows these principles. While agency policy may outline documentation in the patient's record, nurses continually use critical thinking and judgment to determine the focus, depth, and frequency of such documentation. So multiple healthcare team members document in a progress note the patient's progress to recovery. Nursing uses many formats for this. We can do narrative charting, SOAP, PI, Focus, also called the DAR. These are all very common. The local agencies in the Eau Claire area utilize the Focus or DAR format, so that's what you're going to be taught in this program and then also using in the clinical setting. This is just a DAR example. Again, D is the data. This is where both the subjective and objective data that you have collected will be stated. The A is the action. What did you do as the nurse? And then R is the response. What was the patient's response to that nursing action that you did? These are just some other important tips on accuracy. And keep in mind that if it wasn't charted, it wasn't done. So be sure to be as specific as you can in your charting. Make sure that you keep your charting up when you are working so that you are as accurate as possible. To provide safe patient care, nurses communicate with all members of the healthcare team. Reporting off occurs at change of shift, during patient rounds, during patient and family care conferences, or when calling a provider to report a change in status or an update. An organized tool such as the SBAR helps ensure complete and organized reporting. SBAR was first developed by Kaiser Permanente in Denver, and it's supported by the Institute for Healthcare Improvement. So S is the situation, state concisely why you're communicating. B is the background, describing the circumstances leading up to the current situation. Here you're going to give your objective and subjective data that's pertinent. A is your assessment or your conclusion about the data, and then R is the recommendation, making suggestions for what needs to be done to manage the situation. Again, the SBAR provides that standardized format and helps prevent kind of a rambling report. Beginners often write a draft of what they want to say before contacting a provider, and that's a skill that you'll want to practice and you'll get more comfortable with as you do it more often. And this is just a sample SBAR, and this ends the lecture material for this unit, so I will see you all in class.